Good afternoon. I am Dr. Rolanda Johnson, Associate Dean of Equity, Diversity, and Inclusion, and Assistant Dean for Academics at Vanderbilt University School of Nursing. On behalf of our Dean, Linda Norman, I welcome you to this very timely and important topic, where our esteemed panelists will discuss mental health as it relates to Black or African American populations. Here recently, the Health and Human Services Office of Minority Health have cited that in the US, Black adults are more likely than white adults to report persistent symptoms of emotional distress, such as sadness, hopelessness, and feeling like everything is an effort. Many Black adults live below the poverty level, which creates the situation where they are more than twice as likely to report serious psychological distress. Despite these needs, only 1 in 3 Black adults who need mental health services actually receive it. So there are health disparities really in mental health as it relates to Black populations. So welcome to this panel discussion, and thank you, Betsy Usher and Sarah Putnam, for developing this panel discussion and creating this opportunity for us to learn, to grow, and communicate with each other about mental health for African Americans. Thank you.
Thank you for that introduction, Rolanda. We have one panelist that's running a little late, but due to the ground that we have to cover today, we're going to go ahead and get started and allow him to jump in when he gets an opportunity. I want to thank you all again for coming in and donating your time to us for this panel today for this ever important topic. And we have a list of questions that we've compiled from our participants today. So I'll get started with the first. Can you guys describe to me what you think the current state of mental health is among Black Americans today? Carol, I see you're unmuted, so I'll let you get us started today.
Well, first, several African Americans, as was stated earlier, are oppressed and in an oppressed community. Recently, I have been employed in west side of Chicago, and I'm dealing with a population that is extremely oppressed. And I had to alter my assessment in assessing them. For example, I was told as a young woman that depression is a luxury that a Black woman cannot afford. And so depression, the word depression, has a stigma to it. And so when you ask a person, are you depressed? When I scale, I scale feelings, thoughts, and actions. So when I scale depression on a scale of 0 to 7, they will score it low. But when I ask the question, are you stressed out? Or are you tired emotionally and physically? Have you lost joy? Those questions will score higher. For example, irritability. When I ask irritability, that will score low. But when I ask, can you snap? Go from 1 to 100 in a matter of seconds, and they score higher on that. When I ask them questions about like flashbacks, if I ask the word flashbacks, it will score low. But if I ask, what about reliving horrific memories? And then they'll say, yes, I relive when my friend died in my arms. He was shot to death. And so it is a different set of dynamics. And what I have found also, when I ask questions about their health, and I ask have you had any surgeries? Or are you, and they'll say no. But then when I ask, have you had any stitches? Oh, yes, I have 47 stitches in the back of my head where I was hit in the back of the head with a crowbar. Yesterday, I interviewed 2 men. Both had been struck with a crowbar in the back of their head and had to have stitches. And I had to have X number of stitches when I got hit in the face with a gallon liquor bottle. And so when I ask stitches, it gives a whole volume of information that I would not have gotten if I just asked about health, surgeries, etc. And so the oppression is so great in interviewing people who just so stressed out, survival, the mere survival, they cannot even climb Maslow's hierarchy of needs and go to, love, comfort. It's all about survival, eating. And in the food that they eat due to economics is poor quality food, high fat, high sodium. And therefore, as I tell people, wherever Mr. Salt goes, Mrs. Water follow. And so you got hypertension. So you got poor health. You got poor economics. You got so many problems that the question is, where do we start?
Thank you, Carol. One of the things I definitely heard from you in your response was how communication and the language that we use is really important in assessing our Black patients. Anybody else on the panel want to add to that?
Just as you said, Carol, we've really seen a number of the current issues that we thought we may have addressed, but certainly 2020 laid bare how much we still have to come. But I think because of that, even though we know that there's still areas in language, in access to care, a number of barriers for Blacks and people of color to get the mental health attention that we need, I have some hope because the information actually is out there now for everyone. It's very hard to see, or very hard to say you don't see that, yes, the oppression and disparities are there. So now the impetus and hopefully the motivation to make these changes will be here. Just us getting together to talk about what is the state and what do we need to look at moving forward says we know that we need to bring things to a much better state than where they are. And so that gives me hope that with recognizing the needs for language, overcoming barriers for getting mental health, such as access to care. If mental health isn't close to where you can get to it transportation-wise, it's harder to reach. If it's not in the color or language or dialogue, or if you don't feel like you have a connection or rapport with the person that you're meeting with, that's going to be a barrier. If insurance to pay for those issues and pay for that care is going to be a barrier, just as you said, when we're working on having food and housing and shelter from the cold, we don't have time to say, oh, and I'm also having issues with anxiety. I need to go and get help. Those priorities aren't there. So as we address those barriers and we recognize how much, and if nothing else with COVID, and with a lot of the social and civil upheaval that really allowed us to see how far we do have to go, there's hope that we can really look at making those efforts to move forward in a positive way.
Absolutely.
Yeah.
So I think we would be remiss if we didn't look at the mental health issues across the lifespan. When you think about our elderly patients who may be isolated due to the pandemic, then we get to our 50 to 65-year-olds who are starting to experience a new change in work environment. And we look at others who are isolated because their work environment has changed. And we think of, and they start to show signs of depression, anxiety, worried all the time about what's next, and loss of jobs. So as we look at that across the lifespan, I find the greatest hope in our young adults and teenagers. They're more open to therapy. They're more likely to access therapy if they have those opportunities, and the barriers, Tanya, that you just discussed are not part of the issue. And then when we look at pregnant women, they feel depressed or hopeless about the opportunities for their deliveries. Things have changed. So when we look at the mental health status and mental health issues across the lifespan, we have to take different considerations. I do feel recent unrest, civil upheaval has shined a spotlight on the need for African Americans to actually seek self-care and to care for and make that a priority, because we know we are prone to taking care of others before we take care of ourselves.
Now, Anitra, you just hinted on trauma to some degree. Sarissa, I wanted to circle back to you and ask you, do you feel that people truly understand the effects of trauma, even on children?
Oh, no. I think that we have a lot to learn about trauma in terms of the long-term implications. As Dr. Carol or Dr. Rolanda was talking about earlier, just around people of color being more susceptible to having higher ACE scores, but certainly there are implications as it relates to cultural trauma as well. I'm actually formulating a training now on racial battle fatigue, where individuals who have come up within the system and have encountered oppression over and over, what that looks like, as well as individuals who are fighting against the system. And racial battle fatigue actually looks a lot like PTSD. And so a lot of those symptoms in terms of nightmares and flashbacks, and of course, as Dr. Carol talked about earlier, there may not be a recognition that some of these events are traumatic, because what is traumatic oftentimes within these communities, being hit in the head with a crowbar, having a parent or a spouse or someone who's an alcoholic, that is the norm. And then oftentimes individuals who've experienced trauma, they duplicate that in their adult life as well. So we see this serial trauma that's taking place in the larger context of cultural trauma and oppression. So I think there's a lot that we have to learn, and we know that individuals are more susceptible to both mental health and physical health. So how great is the disparity, Letizia? We don't know, because it's compounded. But as Tanya said earlier, I do have hope, because there is a lot of information that is available. And I'm encountering many individuals who are actively in treatment, young adults, even middle-aged adults, and even I'm noticing that a larger percentage of my patients are people of color as well, African Americans. So I think as the information gets out there and there's more education, which is what I focus on, educating communities on the importance of prioritizing their mental health. I think that we'll see greater improvement in outcomes as well.
I agree with all of you all. And I would like to add is that the trauma, for one, we fail to recognize it. Two, we tend to self-medicate it with alcohol and drugs. And with the pandemic, since we are socially isolated, substance use has increased. And so that is a concern among, that is a problem.
I agree. And sorry about being late, mental health calls. And so
we're glad to have you, Asa.
Yeah, and I'm glad to be here. Along those lines of trauma, I think about our younger population in terms of the overdiagnoses of other disorders that may mimic the signs of trauma, to include but are not limited to ADHD. And this is particularly important to note when you're thinking about younger children, especially our brown boys and girls. And so when we don't address the ACEs studies, as Carissa indicated earlier, we'll begin to see structural changes in brain development, and those things really follow the individual throughout the lifespan. And so the deleterious effect is often hard to overcorrect or to compensate, because we have not addressed the issue earlier on with that particular individual. And so we see outcomes that are related to not only their mental health, but their physical health as well. So we see the increase in diabetes, hypertension, cancers, and the like, because we've not diagnosed the individual appropriately. So trauma, I think, in my practice, in my experience, has sort of been the undergirding event that sort of helps or informs the individual's overall health and health outcomes. And so those are things that I think that we need to address sooner rather than later, because they do have that downstream effect that our patients are oftentimes not able to come back from.
Mm-hmm. I want to add to that, Lisa. Oh,
go ahead, Charissa. No, go ahead.
I do want to add to that because I conducted a training about ADHD specifically and the overdiagnosis in individuals of color, particularly with young Black men. And one of the things that I found in the literature, and I can't remember where, but it was almost kind of positioning ADHD as a diagnosis of privilege. From the standpoint that if we diagnose a child with ADHD, then they have access to specific resources such as a 504 plan, they may receive accommodations, they may receive more understanding from the individual administration, teachers, educators, as opposed to them acting out and misbehaving as a result of their trauma and then being labeled as ODD. Then we have individuals who are encountering the juvenile justice system and, you know, delinquency and those things. So I thought that was a very interesting perspective from the standpoint is almost like you want your child to have ADHD. Even if it's trauma, you want them to have ADHD because they gain more compassion from that diagnosis. I thought that was like really interesting.
Yeah, and I think that's one of the, I think that's one of the structural issues that we have to address when it comes to inequities, because important or inherent in that is contextualized models of care. So what we're seeing is our brown boys and girls are being forced into one size fit all models of care in the absence of context. Then what may seem to be a privileged diagnosis actually is upending the child's entire life. And so we're seeing that school to prison pipeline that you talked about and alluded to. And so those interventions are not culturally tailored to that population. And so we're missing the mark completely. And then not to mention the pharmacological implications of stimulant medications in the absence of an attention deficit, right? And so when there aren't attention deficits, those stimulant medications are actively acting like a cocaine or methamphetamine. And so we're seeing increase in behavioral issues and not the opposite of what it would do for someone who has organic ADHD. So it's a misservice for that individual, certainly.
Also,
now, you guys were, oh, go ahead, Carol. I'll let you go ahead and finish your point.
Also, I have seen traumatized children exhibit symptoms of ADHD. When a child lacks coping mechanism of dealing with trauma, such as sexual abuse, etc., they will become overactive. They can't be still. So they would tend to act out the symptoms of ADHD because they lack the words and they lack the coping mechanism to express what is exactly going on. And it's actually trauma and it's not ADHD. And I talked about the misdiagnosis of ADHD in a journal article in 1996.
So Leticia, before we step away from trauma, I think it's important that we recognize the origins of trauma in the African American.
Yes, please share that with us.
As we look at our start in this country as African Americans and Black, from being kidnapped from our native land and being brought to a country here where, and tied and chained to each other, to others who may have not even spoken our language on a passage here. And so when you think about that trauma and how it's passed from generations, a recent study among Jews who endured the Holocaust versus those who did not showed significant health disparities in the group who were part of the Holocaust, even the descendants of those that were actually in concentration camps. So our trauma rooted in our fears from day-to-day life often come out and are misdiagnosed as specific things such as anxiety or ADHD in our children. So thinking about the root of that and being able to get our patients to explain that. And as Carol stated, communicate, finding a way to reach them to get the answers that you truly need to treat.
Thank you, Anitra.
Yes.
And then you have
definitely needed that.
You have to look at the depression. Severe depression can have psychosis, where you hear voices and see things. And soon as if you can look at the symptoms presented by a white person and the symptoms presented by a Black person. If a Black person most often say that they're hearing voices, the first diagnosis that they get is schizophrenia or some type of psychotic disorder. However, those same symptoms with our white counterpart, they will get major depression with psychosis or bipolar with psychosis. And so oftentimes I've seen so many people misdiagnosed with schizophrenia. For example, I assessed a woman one time. She told the doctor that she was depressed due to grief, and he diagnosed her with schizophrenia. This woman wanted a lung transplant, and she was being refused a lung transplant because he diagnosed her several years ago with schizophrenia, and she didn't have schizophrenia. And so the misdiagnosis period is a problem in mental health among Black Americans.
So you guys have done let me ask this next question, Tanya, and see if you can, because I'm coming to you. I want to hear from you next. So I'm going to see if you can incorporate what you're about to say into this next question. I was going to say that you guys have done a great job setting up the framework for where we are now, what the barriers to care are, explaining trauma and the origin of that. And what I'd like to get into for a little bit of, is how do you, as providers, help patients locate services in our community, because we've just heard that that can be a barrier to care for sure. So Tanya, I'm not really sure what you're about to say, but if you can try to incorporate that, that would be great.
I think I actually can. What I was going to mention was, as Anitra and Carol had said about looking at what we feel as some of the historical trauma issues, but actually reframing some things that are culturally based as resiliency. When we talk about getting strength from the ancestors, that isn't a psychosis or a paranoia. That's reaching back to say, okay, I know if my grandmother raised 6 kids after her husband died and all of them went to college and had graduate degrees, I know I can figure out how to get through this next stressor. Now that does put additional stress on us though. And some of those same things can also build to some of the generational issues that we have mood-wise. But a lot of those cultural resilience factors, when saying, okay, if my ancestors could manage slavery, I can certainly manage this boss. Then we don't always translate those in the appropriate framework that they are, so that those access to care issues that you asked about, Letizia, we don't always bring those cultural inclusion and cultural strengths to therapy and activities. One of the easy ways to look at that is if we look at different types of therapies, cognitive behavioral therapy. That can be helpful to look at reframing thoughts, but we also need to bring the strengths of the culture to bear as part of that. So if I'm having a negative self-thought, and in CBT, they try to teach you how to replace that with a more positive one. If I have the strength and resilience of these ancestral factors, that can be incorporated into part of those positive thoughts that I'm utilizing to help. Okay, so that I'm saying, okay, if I was raised in the church and think about the ancestors, what are the positive things that you can use when you have those negative self-coping, those negative self-thoughts, and using that cultural framework as a foundation to help with therapy. Because many times people might go to an appointment or go to therapy, but there may not be the rapport or the level of understanding of where some clients are in discussing with their providers, so that there's not really a click or a fit. And so they may go for that first appointment. Well, I was discussing their job and they just kind of cavalierly said, well, why don't you leave your job? Not recognizing, okay, what may have had to happen for you to get to that job before going to the next. And so those types of things that prevent rapport building in therapy, when we utilize some cultural resilience factors, they can actually improve continuation in services, as well as access and some of those barriers that you were mentioning before.
I'll take a stab at that question too. I think cultural competent providers are important, especially with African Americans, because we don't want to be othered. So what do I mean by that? We already have sort of a layer of racism and the injustices that we experience, and then you layer that with a mental health disorder, then you become other. So I think it's important to have culturally competent healthcare providers. And so one of the ways in which we could do that is connecting people to the Black Emotional and Mental Health Collective, BEAM. And so that's a sort of a collective of therapists, psychiatrists, and mental health providers that are specifically and unapologetically geared toward understanding healthcare within the context of the Black community. I think about Psychology Today. There's actually a search tool within Psychology Today that actually lets you filter the kind of provider that you want to see. So you can put in the search bar, African American provider. And so those are just kind of two areas that you can sort of use as a means of connecting individuals of color to providers of color, or at least culturally competent providers.
And we also have to have more of those providers in the market. I'm a product of the Minority Fellowship Program, which was a program to help not only financially assist in completing my doctorate studies, but also emotionally assist in some of the stresses that come with higher level academics or having a life in academia as a professor and moving through tenure. Those are particular issues of stress that may discourage people from looking at those types of professions. But the more diversity and inclusion that we have at those roles, the more people you can find when you go to those search. And when there are committees that make decisions in terms of treatment, in terms of policy, then you're going to be more likely to have those same people of diversity in those at the table making those decisions and discussing that, okay, we're not going to report that this is something, or if someone says that they hear their ancestors and that encourages them, what questions do we ask before we get to say that they're schizophrenic? That may actually be a resilience and a strength. So we're not going to look at calling that or labeling that. But it took those same types of having those people at the table to be able to make some of the policy changes that we've seen over the courses of the DSM to look at how we diagnose and certain disorders.
So Asa, I would like to say, I use Psychology Today as owner of a primary care practice for almost 7 years. That was my primary way to find psychologists, therapists for African Americans. And I can say over the years, that number has grown exponentially. And in 2010, 2011, when we first started out and we were trying to use different tools to find them, it would maybe be one African-American female. Rarely did we see an African-American male. Today, if you were to search this area or the state of Tennessee, we can find quite a few African-American men and women providing services from our young children to end of life. So very important. That tool is one of the primary tools for primary care.
Good. Well, since we've established that, I want to kind of address the elephant in the room and move on to COVID. It's something that it's been a hot topic for a very long time now. And you guys have probably been watching the news. COVID is said to cause more deaths among Black people, yet as of right now, only 5% or so are vaccinated. Why do we think that is?
Tuskegee. The Tuskegee experiments.
Yes.
Ms. Eunice recruited approximately 600 men, Black men with syphilis, and they studied, and it started in around 32 and it ended in the 70s. And so, and then the HeLa project, where they used her cancer cells, they were immortal cells, and they made millions off of it, and the family didn't know, had no knowledge, and the family lived in abject poverty. And so we have been used, as African Americans have been used in experiments that we didn't have any knowledge about. It was not an informed consent. And therefore, a lot of people are saying, they're not experimenting on me. I'm going to wait and see what happens first.
I've certainly heard that, Carol. Sarissa, it looks like you had something to add.
Yes, and I will be honest in that I certainly wanted to wait to be vaccinated. Even as a healthcare provider, I wanted to see the effects of it. And it could just be my skepticism. It could be because I'm a person of color, but I did see several posts, on social media that, saying things that were probably not pleasant. If white people are getting the vaccine, then, then we know it's legit and we should get it too. Even some of the local hospitals here where I am in South Carolina, when they did a media broadcast of the first person that was vaccinated, it was an African-American person. And I think that was very strategic to encourage people of color, Black people, to actually become vaccinated.
I think also it's important to talk about is the deprioritization of communities of color in the distribution of the vaccine. And so I'm recently relocated from Washington, D.C., and I was reading an article in the Post about Prince George's County, which is largely an African-American county and a well-to-do county in the state of Maryland. And then you think about Anne Arundel or Annapolis, Maryland. And so what they were seeing was the amount of individuals who had been vaccinated or inoculated in the Anne Arundel area was 2 to 3 times more that of individuals in Prince George's County. So I think that when we were implementing a strategy for how to vaccinate individuals from communities of color, we didn't take into consideration access to technology in terms of how to navigate computer systems. Certainly there were inadequate sign-up mechanisms for individuals who didn't have access to computers and things of that nature. So when you think about it, some of the social determinants of health that we talk about with access to certain technologies and things of that nature really preclude individuals of color from being able to access some of those things. And so I think until we unapologetically say that we need to prioritize communities that have been disproportionately impacted by COVID-19, that we're still going to see this lag in the amount of African Americans who are being vaccinated or people who come from populations of color as opposed to the mainstream population. It just has to be an emphasis there in ways that are not just happenstance or ad hoc. They need to be implemented, and there need to be policies that ensure that individuals in communities of color who want to be vaccinated have the access and priority to those vaccines.
That's an insightful comment, Asa. I hadn't really thought about that, but I've certainly had people reach out to me to help them sign up online. And I hadn't really put that together. So thank you for sharing that with us. As we kind of continue this dialogue with mistrust, we've talked a little bit about clinical trials and some of the historic trauma. What else would you guys add as far as mistrust that Black Americans may have with the health system? Anything else that you guys would like to add about that particular conversation?
The continued encounters, sadly, Tuskegee, the use of Black women's bodies for the development of OBGYN surgery, certainly that's the historical foundation. But even today, providing education, providing a provider and a client interaction that's positive and empowering, those things still occur. When many Black people go into the healthcare system, one, they're already delaying care because they're anticipating potentially having a negative encounter from what they may have heard throughout the community. When they do have those encounters, they may initially see potentials of prejudice or stigma, minimizing your report, minimizing what you say or your symptoms. There was a 2016 study done with residents and doctors that still felt that Blacks felt less skin pain because there was more melanin in their skin. And so in some way they didn't have pain in their skin because the darker skin was thicker. So we still have things that we have to dispel in the medical community that propel these continued lack of trust. So education is the important part. One of the ways that we look at education currently is community engaged education. So that when we talk about here's a new vaccine, but it actually isn't new. The technology for this vaccine has actually been the technology for this vaccine has been under development since 2003. So we can provide education to this community. We can have people of color. One of the main NIH researchers is African American. No, and have that. So no, this is what has happened. It's been developed over this past year, but the technology behind it in mRNA is actually been developed since 2003, because we had other types of coronaviruses, SARS, MERS, that we've been working on vaccines on all this time. So this isn't quote unquote as new as we might think, because when you provide that education, plain, simple, straightforward, so that you don't feel like there's big question marks that aren't answered, because that's when conspiracy theories fall into play. And that's when we start to wonder, is it affecting my DNA? Is it making me sterile? Is there a microchip in it from Bill Gates? When we answer those questions honestly, yes, and have a discussion where we know, hey, these people have been involved. This actually has been the product of about 10 to 15 years of work, with a whole lot of infusion of money this past year, given the fact that it was a global pandemic. Then people are less likely to have some anxiety. But it's really meeting with the community, meeting with churches, community leaders, and even during this would have been virtually. If good education had been planned, this could have been a better rollout to have people less anxious about the possibility of the vaccine. Absolutely. Even now, we're, and the American Nurses Association is currently working on developing similar webinars such as this, where people can log in and ask the nurses, because nurses are the most trusted profession, what are they thinking, and ask these types of questions. And we're hoping now to look at decreasing some of that literacy gap and educational gap about the virus that will lead to a lot of, and vaccine that leads to a lot of anxiety about getting the vaccine.
Tanya, I do believe that you have a midwife's heart. You instantly went to the gynecological mistrust with the development of the speculum from Marion Sims from on slavery women. And that was the first thing I thought of, not necessarily the Tuskegee, because that's more recent. I think about the enslaved women who had to endure so much pain to find the speculum. And that seems to, it has been across the lifespan and generations here in America, how African Americans have been used for guinea pigs. And you also think about eugenics, and the Mississippi appendectomy, where young women would go in for certain procedure and come out sterile because they were given a hysterectomy without their consent or knowledge. And years later, attempting to have babies or become pregnant, and they aren't able to, only to learn that some previous surgery, someone took their right to be able to have children and reproduce.
I think we also need to think about specific to psychotropic medications, the medications that we give to individuals who have psychiatric disorders. And so thinking about cytochrome P450, which is an enzyme that can either be induced or inhibited based on the drugs that are given. And so in the absence of individuals from populations of color that are included in those clinical trials, the less efficacy we see in those medications when we give them to the patients. And so I think it's important for African Americans to be involved in those research studies and things of that nature, because of the implementation of medications that can have serious clinical and significant, like drug-to-drug interactions and things of that nature, if it hasn't been studied on the population that we're giving it to. So it's not just, some of the things that they've done from hysterectomy, histological issues, but just sort of like the amount of drugs that we have are very limited. So if they're not going to be effective in the treatment of depression or anxiety the way in which they are in mainstream culture, then it really sort of leaves individuals of color with very limited treatments. And oftentimes we can go long periods of time where medications aren't effective. And these individuals have been very skeptical of psychotropic medications in the first place, and sort of the untoward side effects that they may experience, they may never go back to another drug. And so I think it's important that we understand that maybe we have to hit the iron while it's hot. And so we get one opportunity to engage in a community that is skeptical. If we don't have the appropriate interventions, then they may never come back. And ultimately, I've seen depression end up in schizophrenia or untreated trauma, in very impactful ways that I think that individuals are not able to recover from because the interventions were ineffective and they didn't trust the system in the first place. So we got to be upfront about that particular aspect, is that if we aren't present in the clinical trials, then we miss our opportunity.
Absolutely.
So it's definitely, you know, what I'm hearing from you guys is that it's important to make sure that we have Black people part of the clinical trials. They need to be part of the research so that we can expand the types of treatments that we have available for them. Now, Tanya, I think when we met last time, you talked a little bit about work that you were doing in the NIH on the drug abuse task. Do you mind expanding on that a little bit for us?
Sure, because it actually is the natural consequences of what you and Asa were mentioning. NIH actually did a review of their clinical trials, all the tests and studies that they run on their medications, treatments, and services for mental health and substance use issues. And they were looking at the percentages of Blacks and other people of color in these clinical trials, because it's hard to make generalizations about healthcare outcome and treatment if we don't have the number of these clients needed in that trial for any type of power for the results. When they saw those numbers and the abysmal percentages of minorities that were as part of these trials, they actually created the Great Lakes Clinical Trials Network in March of 2020 for the development of clinical research, particularly with Blacks and other Indigenous people of color. So there are 8 medical schools that make up this Great Lakes Network from Indiana, Illinois, and Wisconsin, of which I'm the assistant director of the program there and the director of the community engagement. Because when we want to look at engaging the community and having them feeling more comfortable with participating in clinical trials so that they don't have that guinea pig feel or immediately, report Tuskegee, then we include them in actually the discussion of what should we actually be studying, what are the concerns and needs you have, and then how do we bring that to bear as a clinical trial and actually kind of turn the tables. We normally come up with the ideas and say, okay, let's do these trials on these people. Now we're asking the people, what are your concerns? What are the issues in your community? And then we as researchers are taking that and turning that into clinical trials. And so it's been interesting in what we've been working on currently. First, and one of the most important, is a way to look at addressing from an interactive nature, stigma from clients and providers. So our first concept paper that will be one of these clinical trials papers will be looking at interviewing people who've had negative experiences with stigma in hospital care, using their qualitative based results, using their experiences and perceptions to then tailor the intervention to help providers see what they need to be doing in terms of their behavior, and then hopefully also changing their attitudes, but particularly the behavior of how they're interacting with clients in the emergency room. So we've actually just gotten the go-ahead for this first clinical trial, which certainly is going to be the impetus to start to address some of these ongoing medical encounter issues that we see. We're also working with ways to, how do we encourage people to feel comfortable taking a medication that might help them get off heroin or other substances? Because we know that substance use has one of the highest levels of stigma of any medical issue, but it's a medical issue. If your diabetes, if your blood sugar was 500, we wouldn't say, well, your blood sugar is dirty. But if you're positive for heroin, we say you've got a dirty drug screen. So we really need to look at changing the language of how we look at considering drug use and drug misuse, and how we encourage people to feel comfortable getting help for that. And we're looking at community interventions with churches, at other activities. Even though we're doing some of those virtually now, we're setting the steps so that churches can give us input, so that areas that are in the community already can give us input on how to look at tailoring these interventions. And we're certainly hoping to look at better outcomes and being able to report back. That's another one, accountability to the community, reporting back to the results on what we find in these clinical trials.
That work certainly leads us back to that hope that you and I believe Sarissa were talking about when we first started this conversation. So with that being said, I'll ask the rest of the panelists, what are your solutions that you see through your work? What are solutions that you're seeing through your work right now for Black Americans in mental health?
Accountability. oftentimes we want to make excuses for our actions. And there's an inverse relationship between excuses and responsibility. Increase in excuses is a decrease in responsibility. A decrease in excuses is an increase in responsibility. So I, as a clinician, a provider, I try to make my patients accountable for their actions. And until they become accountable, I don't think that there could be much change.
I think for me in my work, I'm responsible for the integration of psychiatric service into the primary care model. And so I think that's of the utmost importance for African Americans because that's primarily where they receive their treatment. And so they are not in situations where they have access to psychiatry outside of their primary care setting. And so I think the integration of psychiatry in primary care is going to be important for access. And then on top of the access, I think it's important for, again, the cultural competency piece to be in play. Not only do they need to have access, but they need to have access to good quality mental health services. And so African Americans have traditionally utilized their PCP in the emergency room. So looking at ways in which we can do, I hate the word ED diversion programs, because if there are, in the absence of access, the emergency department is oftentimes the only place that people can receive services. So I think that that is a misstep, if you will, if we just continue to say, well, Black people just go to emergency rooms when they're sick. Well, Black people go to emergency rooms when they're sick because that's the only place that they have in their communities for access to care. And so I think that integration piece is going to be important. And it really sort of solidifies and validates the experiences of Black people, as opposed to saying, well, you don't even know how to use the healthcare system. Well, guess what? There are structural inequities in place so that people of color don't know how to access and navigate the healthcare system, which is also a barrier for people of color. And so I think the integration piece into primary care lowers that barrier significantly and increases access where people are traditionally getting their healthcare.
I want to talk for a moment, Letizia, about visibility and in terms of, as an African-American provider, being okay with being token in a sense, for lack of a better term. As a young person, I wanted to be recognized for my efforts and, all of these things. But as I've gotten older, I understand the importance of me being at the table, as Tanya talked about earlier, and advocating for people of color, but just being willing to be open and share our experiences and have some of those difficult conversations, really dispel some of the stereotypes and things that are associated with our communities, and just really taking on that responsibility. Early on as a provider, when I was first starting out and patients would walk into the room, for whatever reason, I was very keenly aware of the fact that they were surprised when they saw me, whether they were white or Black or whatever. Everyone was surprised that I was there. And now it doesn't, I don't notice it so much anymore, but I think in those moments, I really recognize the importance of my role. And as Anitra said earlier, as we get more and more people of color in mental health roles and in healthcare provider roles, I think we'll see more responsiveness and more openness as far as people seeking healthcare and really getting the help that they need. And then also community engagement. And I know that everybody's not called necessarily to grassroots, but because we have this knowledge, I feel like we have a responsibility to engage. And so people are reaching out to me all the time. Everybody knows I'm in mental health. Can you help me with this? Or can you help me find this? And just being open and willing to help on that level as well. Our family members, our friends, everybody, because we recognize that there is that correlation between mental health and physical health, and it's all important. You can't have one without the other.
Yes. So go ahead, Anitra.
So in my role as Director of Clinical Services at Pop Healthcare, we are responsible for about 30,000 assessments in the home settings a year. So my role, I make sure that we're hiring a diverse group of nurse practitioners. So upwards of 150, between 200 clinicians. I'm helping to create policy to ensure that the members that are seen actually have ways to access healthcare in terms of mental health, primary care, and specialists, creating SOPs, policies, and then making sure they're trained to those SOPs and policies so that we can impact a larger part of the population. And that includes Medicare patients, ACA patients, as well as Medicaid patients. Not on the front lines with some of you all, but definitely making an impact for a large group of people in the United States.
Those are all some pretty great next steps. I feel like the health of Black America and mental health is in good hands right now. In my efforts to keep us honest with time, we have about 7 minutes until 6 o'clock. I want to kind of ask like a final question or two. So I'd like to wrap it up with more of a personal question from you guys. What do you do to take care of yourself, and what would be your words of advice for students of color who are also thinking about change for the system? So if you can kind of give us a short blurb on that, both of those questions to kind of wrap us up.
I
know it's hard to talk about yourself.
I know. So we cannot get away from this pandemic. So one of the things, well, I have a system. First, I've set boundaries. I've learned to say no. I have carved out time for myself to make sure that I remain healthy with the whole notion of self-care, self-love. I cannot pour into others until I pour into myself. So, and then finding something that I love to do. For me, exercise is my outlet. I flipped tires this morning in my workout. So that is my thing to keep and protect my mental health. What was the second part of that question, Letizia?
What would be your words of recommendation or your words of encouragement for Black students who are trying to do the same, who are trying to make changes in this system?
I would say follow those steps and stay the course. Nursing school is difficult, and you haven't gone through nursing school if you haven't cried at least once. So recognize that we have all been there, that we have persevered, and we can make it. And your decision to go into medicine is too important as a minority not to finish the course.
I'm a creature of comfort. I exercise. An A student, in order to be an A student, you have to have proper nutrition. You have to have exercise. You have to drink plenty of water. You have to focus and give your attention to your studies. But you also have to have a work-life balance. And so you have to do things that you enjoy. I had workstations when I was in school everywhere in my house. Even though I'm doing other things, I have something there that I could be working, constantly studying, as well as interacting with other people. One of the things that I'm doing now in the midst of COVID, my neighbors and I have social distance time. And I sit on my porch mostly in the summer months. They come, bring their chair, bring their beverage, and they sit 8 to 10 feet apart. And we talk, we laugh, some play music, etc. But it's a way that we connected. And as a result, my neighborhood has become a very tight-knit group. And they have become my extended family and a main sense of support for me. And so that has helped me through COVID.
Thank you, Carol.
The support network has been what's kept all of us together through all of this time. And that's been 2-footed support as well as 4-footed support. I know so many of us have spent time in playing with our pets. I know they have enjoyed our being home so much more. I'm not sure they're going to be too happy when we actually do start getting back to work. But those things that are close to you and activities that you enjoy are always so important. I've actually gotten a yoga mat and started doing more yoga for stress, because we're now sitting in these seats so much more even than when we were in the office. So what are the things that you're doing? And remember that, just as you said, you have to be in a good place to be able to work and help others. What I'd say to students of color is basically what my grandmother, who was the woman who helped those 6 kids all go and have graduate degrees in education, is to keep on keeping and keep on reaching until you reach your goal. When I was younger, even in high school, I thought about being able to make change at a national level, because I saw a lot of the struggles that we went to from day to day, especially in regard to health. And I was always interested in science. So even when I was little, I would say, oh, working at CDC, working at NIH, that'd be so cool. Now, of course, there were detours along the way, but those detours allowed you to learn to bloom where you were planted. And so one of those detours took me way out to the border of US, Mexico, and working with farm workers and immigrants and refugees. So while I was there, I learned Spanish. So I bloomed where I was planted and did that. Somebody saw that work and said, hey, let's keep on reaching till you reach your goal. Let's have you at a university and developing and going into the community and learning more and teaching this community engagement. And so when NIH said, oh, we need to have a community engaged process, that's when you kept on reaching till you reached your goal. And now you're able to be at a spot where we're really looking at making these differences, not only regionally, but on a national basis, to really make the changes, to make what you see and the changes that you growing up with. As a student, take that in your mind and put it in your heart, and then keep on reaching until you reach your goal and what you want to do.
I agree.
Thank you. Sarissa, Asa, you guys want to add to that?
Well, I'm trying to be a gentleman and let all of the ladies go first. So, Sarissa, I will let you go.
I think what everyone said has been key, just making sure that we take care of ourselves so that we can be of service to others. I've been doing a lot of self-care kind of workshops, and one of the analogies that I like to give is, imagine that you were given $1 million from the time that you were born until you die, and that's all you had. Right. And most of us wouldn't just buy like a Maserati or buy one fancy car and spend it all in one place, but we would maybe figure out ways to replenish it, figure out ways to multiply it. We might invest it. We might do all of these things. We may give a little here, give a little there, so that it could last us until we die. And so the quote that I like to say is, self-care is not selfish, but it's stewardship over the one gift that you've been given to give to the world. And that's you. So I try to live by that, and get you a good therapist, take care of your mental health, and do all the things that you need to do. But it's really about stewardship, and you are invaluable. You're worth more than $1 million. So that would be my encouragement.
Thank you.
Yep. I think for me, I view my job as mending fences. And I think about Nehemiah, who's a biblical character who was responsible for restoring the wall. And I think about my work in that way, in terms of providing healing and restoration for people who have mental health issues. But I don't want to do that at the expense of my own mental health and my own well-being. So play, I learned this from Vanderbilt. Miss Rogers, or Professor Rogers, would say, work is the play of a child. Play is the work of a child, right? And so I learned the importance of playing. And so being outside as much as I possibly can has been a blessing for me, because outside is essentially the only place that's open right now. And so getting a lot of vitamin D and a lot of sunlight has been really important for me in this season. When I think about the encouragement of students, there's a quote that my mentor gave me when I left corporate America to come to Vanderbilt. And he said, opportunities of a lifetime must be seized within the lifetime of that opportunity. And so essentially what he was telling me was to maximize my moment, that I would only be a student at Vanderbilt for 2 years. And what I needed to do was I needed to maximize the opportunity that I'd been given. And so students of color, you have an opportunity to be a systems level change agent within a healthcare organization. And when you develop that question, that PICO question of what is it that you don't like about the system and what is it that you need to change, let that question be your driver for what you want to see change within the healthcare system. And the only person that could bring that question to bear and the subsequent solutions is you. So you are very unique in your mission, and you are very unique in your purpose. So if you don't ask that question and answer those questions, then there's going to be a gap that will never be filled, and subsequently there are going to be outcomes that will not improve because you didn't ask the question and you didn't provide that solution. So always be thinking of ways in which you can be that change agent, because in actuality, you're the next generation of healthcare providers that will be practicing within a context that is different than anyone has ever seen. And so your questions will be different, and your subsequent solutions will have to be different. So go and be great. That will be my advice to you guys.
And keep it moving.
I love it. Thank you guys so much. My heart is warm. Thank you for your insight and your information today. And I can't leave this Zoom without saying to the alumni that joined us today, if you are not already a preceptor, please consider it, especially if you are a person of color. It is very much needed. And I hope, it sounds like we had a really good turnout today. I think this conversation could have gone on much longer. So I hope maybe 3-4 months down the line, we all can get back together and expand on this topic as well. So thank you guys. I appreciate it.
Thank you.
Thank you.
Good night.
Good night.
Good
Have a
night.
good night.
Thank
Asa
you.
will lead us in the repass.
That's right. We didn't talk about the repass tonight, but we'll talk about that at another time.
Yes.
All right,
You all
guys.
have a great night. Bye-bye.
Well, bye-bye.
Bye.